Hello, my name is Jordan Mast. I am a PA at the Colorado Neurological Clinic here in Denver. Today, I'm excited to talk to you about brain health and Alzheimer's disease. We've made some incredible advances in both the diagnosis and the treatment of Alzheimer's disease over the last 10 years. Because of this, one thing that has become incredibly clear is our need to identify Alzheimer's disease as early as possible so that we can get ahead of things and these newer treatments can possibly be utilized. We're going to spend some time thinking about the things that keep us from diagnosing patients earlier, some diagnostic tools, and how we can consider the entire patient when assessing cognitive impairment. Let's get started by thinking about the things that can delay diagnosis. I think we can recognize that there are system-level things that can create challenges, but I want to focus more on patient characteristics that we can look out for. This is important because when we consider the stages of Alzheimer's disease, patients in stage 1 really have no cognitive impairment. This is what we refer to as preclinical or asymptomatic Alzheimer's disease. Cognition then declines as the disease progresses through subsequent stages, and disease-modifying therapies are ideally initiated early when impairment remains extremely mild. If we're not able to detect cognitive impairment until later stages, which is typically what we did in the past, the potential that we could help these patients is drastically reduced. One characteristic that can influence diagnosis timing is the sex of the patient. While nearly 2/3 of patients living with Alzheimer's in the US are women, disease presentation is not always as obvious in these patients. One of the challenges is that women generally perform better than men on tests of verbal memory, whereas men often perform better on visuospatial tests across the lifespan. The reason that this creates such a challenge is that many of our early assessments for mild cognitive impairment rely on verbal memory. So while women are higher risk for a variety of different reasons, they're also less likely to get diagnosed early. Another group of patients who may not be detected as early are those with higher IQ or those who have achieved higher levels of education. There was a study done in 2020 that showed that cutoffs used for certain assessments, such as the MoCA, may be too high for some patients. I actually just evaluated a patient recently for MCI whose scores on formal cognitive testing fell within the normal range. However, additional assessment and collateral information made it clear that he was experiencing cognitive decline. This patient had recently begun skipping steps in familiar routines, something that had never occurred previously. Although his screening test appeared normal, this represented a clear decline from his prior baseline level of functioning. In such an intelligent and self-aware individual, his comment to me was very impactful, and he said, "Jordan, I know something is wrong, and I remember it like it was yesterday." Situations like this illustrate an important principle in diagnosing MCI. The diagnosis is based not only on absolute cognitive test scores, but also on demonstrated decline from an individual's prior cognitive baseline, but independence is preserved. Patients with high cognitive reserve may continue to perform well on screening tests and can sometimes beat the test, meaning that subtle but meaningful changes in cognition are only recognized when we as clinicians consider baseline abilities, functional changes, and collateral history. Neuropsych testing can also be helpful in these cases as they can account for patients' high education level and intelligence. We also have challenges when assessing individuals with cognitive impairment or neuroatypical conditions such as psychiatric illness or autism spectrum disorders. To better assess these patients, we need to understand and consider the risks of dementia, their age, how that may impact their condition and their cognitive development, and consider any communication needs the patient might have. Some of our patients are also taking medications that impact cognition. While these medications are serving a purpose, they can make it easy to overlook certain cognitive changes that are unrelated to the medication. In fact, just the other week I had a patient on topiramate for migraine, and I initially assumed that her cognitive symptoms were related to the med in particular. I've been seeing her for years for migraine, and it was really easy for me to overlook her potential to have Alzheimer's disease due to my knowledge of her neurologic condition and the medication she was on. Both of these factors could contribute to her having cognitive problems. But when we dug a little bit deeper, we found out that she truly did have something more. This can be a major challenge for us as clinicians, and especially in patients that you may have known for a long time. A final example I like to mention is when a patient doesn't speak English as their primary language. When we give assessments for MCI in English to these patients, sometimes we can encounter lower scores. It is important that we consider whether we can administer these tests in the patient's dominant language or possibly use specialized culturally sensitive tools or cutoffs to distinguish cognitive decline from their language barrier. I'm sure that you and I could spend a long time talking about different reasons that MCI might be missed early, including socioeconomic factors, the amount of time that we have to spend with our patients, albeit very limited, and other infrastructure challenges. But as I mentioned at the beginning of this video, we have come a very long way in detecting Alzheimer's disease earlier. While verbal and written screening tools remain an important part of the assessment, we're now able to use additional tools to get a more complete picture of our patient's cognitive health. In the next video, I'm going to discuss blood-based biomarkers. In the video following, we'll talk about putting the assessments together to really understand our patients more. See you there.